Good evening, everybody. On behalf of Dr. Hanadi Halamad, it gives me great pleasure and privilege inviting you all for this evening marking the World Alzheimer's Month 2021 events. This event takes the theme of World Alzheimer's Month, which is on no dementia, no Alzheimer's, highlighting on dementia diagnosis, getting it right. This event is collaborated along with support from Team Oman, led by Dr. Hamad Al Sinawi. Today, this evening, you're going to listen to eminent physicians who are involved in the care of patients with dementia, highlighting on the multiple facets in the dementia diagnosis. Yes, in an evening of 90 minutes, I don't think we can cover all facets in the diagnosis, but yes, the crucial facets we will try taking you through. So without further delay, we get on to the 90 minutes dementia diagnosis, getting it right. Thank you. So we get on to our session straight away. So the first online is the importance of timely diagnosis and the role of memory clinics. Ladies and gentlemen, this session is dedicated primarily for Dr. Hanadi. It's just that owing to urgent commitments, she has not been able to take us through this session, but I will take you through what essentially she wished to highlight here. So I have no conflict of interest. So when we look at the benefits or essential importance of a timely diagnosis, we can look at it three levels, at an individual level, from a research aspect, and from a clinical domain, why it is important. So looking at it from an individual level, we don't have to go further far. Marking the World Alzheimer's Month, let's see what the Alzheimer's Disease International, what do they say? And as they have rightly highlighted, the transcript from one of the person living with dementia, as it highlights, I was diagnosed as having the early stages of Alzheimer's disease. While this was a terrible blow to both myself and my wife, we were glad to have been told so that we could discuss the possible effects on our lives and plan how we could adjust to the situation. Essentially, what it highlights is, by recognizing it, by, evaluating and getting to the bottom of it, once we are able to give the right diagnosis to our patients and their families, they get a sense of relief because there is an understanding for them. They know what is happening, why it is happening. So that sense is a big sort of relief in the journey of dementia. It helps in minimizing the stress and anxiety as it gives a meaning to what is going on. On a practical level, as it says, particularly if the diagnosis is at an early stage, a timely diagnosis, it enables in planning the future, because this is a disease which is a progressive disease. It is going to impact on multiple aspects of one's life, one's family, one's society. So that planning, when the person has the ability to understand and express what his or her wishes are, all that aspects can take as highlighted here. If one is working, one can adjust the working conditions, particularly like, we have a patient who is a healthcare professional. He has got a diagnosis, but he has been able to, with his senior managers, the work has been arranged in a way that it does not impact on the limitations that the condition brings in, but at the same time, he gets the sense of, that confidence that he's still able to work and occupy himself and deliver to the best of his ability. So these are things that comes on a practical level. And of course, the support services, not only for the patient, but even for the near and dear ones, they get information of all the support systems that are available, and they know how and when to access it. So all that beneficial importance comes in when you have a timely diagnosis. When you look at it from a research perspective, what the reviews highlight is particularly, when we are getting the patient in an early stage and we have got the diagnosis, there's a lot that still can be done in terms of modifying the known risk factors, ensuring that we have the right control in those risk factors so that the disease progression is, controlled in the best way possible. So by modifying the exposure to the common risk factors. And of course, if the person is suitable for the treatment intervention, that also has its beneficial effect in helping with the slowing down the progression of the disease. Overall, family carers of people with dementia, they are at a high risk of physical and mental illness, and that understanding and ensuring that right support is given from the early stage itself becomes very crucial. How do we look at it from a clinical perspective? So for a patient who's coming to our clinic, and when we go through the journey of dementia, a lot we can learn the importance of a timely diagnosis. Because if we have the right timely diagnosis, as we mentioned earlier, control of risk factors, our patients quite often we find, they are on 10, 20 medication. So a lot of, variables from that factor, address the polypharmacy, minimize as many factors are impacting on the cognition at the very timely way. So that is an important aspect. If the patient has, sensory limitations, we can help to address that, enable them to involve in cognitive stimulation therapeutic activities, enable the support system for the caregivers, and helping as a whole both the patient and the family to cope better through the journey of dementia. And even which I alluded to earlier, tailoring the occupation to ensure that the person is able to work as long as they can within the safety parameters being looked into. Now, again, another very important aspect that comes with a timely diagnosis is, preventing the complications. So if we have the diagnosis, we can put all the systems in place to ensure that down the journey of dementia, the complications are kept to the minimum. In fact, taken away as best to our ability. Right at the outset is the medication, because, even if it is an early stage of dementia, a person left to manage 10, 12 medication itself is, an accident waiting to happen. Either they take less or they take more, and the complications that come from it. Driving accidents, I don't have to go into the details of it. You are well aware of the issues that comes from that. Financial abuse, time and again we come across in our clinic, it is incidents of these complications that is bringing the patient to the clinic. So, once we have the timely diagnosis, we can prevent these complications, the financial abuse which is out there, fire hazards, risk of falls, risk of ingestion of hazardous substances, you name it. So all these aspects, you can clearly at the outset of the diagnosis, you can put systems, communication, support systems to ensure these complications are, taken away. And then, of course, the biggest one that comes there, prevention of delirium, because as you all would be aware, our patients with dementia are at risk of delirium. So understanding and ensuring that there is a clear communication, information sharing with the patient and the near and dear ones, and working through the medical team to keep the risk of delirium at its minimum also helps in a long way. So altogether, all these parameters of intervention helps towards a better quality of life for our patients as the journey of dementia they take through. Okay, coming to the Qatar scene, our memory services are based in Rumeila Hospital, and the first memory clinic was actually set in stone December of 2012, and actually it sort of started up and running in early 2013. And the one person who led it from the start, all alone, none other than our own Dr. Hanadi Al-Hamad. I understand that at that time, it's how a vision of a leader that this is a condition here to stay and grow, and the need that we have to the right clinical services to address this growing cause. She started the journey all alone. Actually, what I understand is, she had her own geriatric clinics. As being a geriatrician, senior consultant geriatrician, she had her geriatric clinic. She had to give up her own geriatric clinic to change it to a memory clinic. She had to cross the hurdles at that time. And for the first 6 months, even in spite of crossing the hurdles, there were hardly any patients. And then also, she persevered with the cause, the need for this clinic. And then, of course, as they say, rest is history. We'll just look at that. So if you look at the Rumeila Hospital, the memory clinic, if you look at snapshot of the early years, the patient profile that used to come to our clinic, more often than not, patients are coming towards the later stages. Majority of the patients are coming on wheelchair. As we go through the history, multiple hospitalizations would have preceded, multiple complications would have happened, multiple bouts of delirium would have happened. They are towards the severe stages of dementia. Care stress was abundant. This is the profile of the patients earlier when the clinics were started. Then came the subsequent years, sort of milestones in the journey of dementia care in Qatar. The World Alzheimer's Month campaigns, just like what we are doing now this year, this took momentum, and we every year during the month of September, this was across the country, campaign was up and running. There was a national community survey, the positive cognitive survey done in the primary care to look at cognitive impairment in the community population attending to the primary health care. That again raised the awareness. Then came very proudly under Dr. Hanadi's leadership, the Qatar National Dementia Plan, which was launched by Her Excellency in November of 2018. This was the first, Qatar is the first Arab nation to have a national dementia plan. And then in the COVID crisis time came the launch of National Alzheimer's and Memory Services Helpline. Inevitably, these major milestones have, done a lot to help in the dementia journey in the country. If you look at the memory clinic now, from where, she started, where she has got it now the clinics have gone from 1 per week to we have 13 clinics per week. We have a multidisciplinary team structure that has come into the memory services. We have a structured assessment that is in place. We also have gone into the primary care, and we have integrated memory clinics in the primary care. Our multidisciplinary team structure in the memory clinic includes, you name it, all the right specialists. You have the geriatricians, you have the geriatric psychiatrist, psychologist, occupational therapist, neuropsychologist, and specialist nurses. Recently, towards the end of last year, actually working in collaboration with the neurosciences department, we are having twice in a month geriatric neurosciences MDT, where complex cases are brought in and we get the experts across the table in one go. The memory clinic also has moved into working along with Team Edinburghs in UK to get the Edinburgh's cognitive examination Kata version, because we realized that the tools that we currently use, which is MOCA, and the earlier use, which is MMSE, these are not culturally adapted. So we've gone the length to have collaboration workshop, and this has been, the tool is ready. It is actually going through our research body to get starting to get up and running with the validation study. This year, Dr. Hanadi's leadership, we have taken a step ahead to initiate cognitive stimulation therapy clinics. Work is in process, hoping in the coming weeks that will be starting soon. Research is another arm that is coming from the memory clinic, both on the dementia aspect with the corneal confocal microscopy research, as well as the delirium research. Now, if you look at a memory clinic, in 2021, I will just share the story of a patient just seen last week. So 66-year-old gentleman, he comes to the clinic stating that he wants to get himself checked out to make sure, because he's read about it, he's made aware of it, of this condition, and he realized that he has a family history as well as he has a vascular risk factor. So, and lately he's having subtle memory concerns. So he wishes to have a comprehensive evaluation. He's working now, he's fully independent, but he wishes to have an evaluation to ensure, and these were his words, to ensure that all his potential risk factors we are optimally evaluating and managing so that he can remain healthy as long as he can. So you can see the perceptible difference between early in 2013, the patient profile that you had, patients coming towards the late stages of dementia with all the complications. And now we have patients coming at the very early subtle signs and wanting to take the help and wanting to remain healthy as best as they can. So that perceptible change has come as highlighted based on the milestones that came on the way. And we are here today. And this month, we have a lot of events lined up, working through the professional group, which is the doctors, the nurses, in our community with the NGO and our caregiver group. So it's a month to learn, it's a month to share, it's a month to experience, and it's a month to do the best that we can for our patients with dementia and support their caregivers. Thank you.
Hello, everyone. Thank you so much for joining this excellent webinar. Thank you, Dr. Hanadi, for organizing this. Thank you, organizing team, Dr. Mani, Dr. Pravija, Mr. Muhammad Sali. It's great to have our regional counterparts, experts from Oman. I would like to wholeheartedly welcome them for this. So with that, let me introduce myself. I'm Dr. Shafi Khan. I'm a Geriatric Fellowship Program Director, Senior Consultant in Department of Geriatrics and Long-Term Care. I have been asked to discuss the essentials of diagnosing dementia using National Dementia Guideline from Qatar. I have no conflicts of interest. I've been asked to do this presentation with three main objectives. By the end of this session, you'll be able to differentiate between normal aging and dementia. You'll be able to diagnose dementia using the best available evidence. You'll be able to outline principles of managing dementia and its symptoms. With that, I would like you to understand a little bit about dementia, such as definitions and cognitive domains that it's affected. So the definition of dementia is it's a clinical syndrome characterized by progressive decline in a range of cognitive and behavioral symptoms and signs, such as loss of memory, language disturbances, reasonable difficulties, personality changes, and amongst all of which there will be impairment of their daily activities of living. The usual cognitive domains that are affected are complex attention, language, executive function, perceptual motor, learning and memory, and social cognition. Let me move on to this busy slide, which differentiates between normal aging and dementia. I'm sorry if my video is superimposing on some of the aspects of the text, but I will go through each and every domain. So let me start with learning and short-term memory. In a normal person with aging, he or she may forget names or appointments, but later they will recall. He or she may misplace things, but they will be able to retrace the steps back to the misplaced item. Unfortunately, with people with dementia, they will not be able to recollect the names of the closed ones. They will not be able to retrace the steps. In fact, they will keep repeating the same information again and again. Executive function. People with aging will have slower reaction time with thinking. They are less able to do multitasking, especially when they are distracted. They need to concentrate more. Occasionally, they do bad decisions, especially in finances. When compared to people with dementia who cannot undertake any planning, they will not be able to do even simple tasks in their activities of daily living. They will not be. They will be doing frequent mistakes in their judgment, especially visible in the finances. Language-wise, there are people with normal aging will have some word-finding difficulties. They'll have some uh, difficulty in maintaining conversation. They'll have to concentrate hard to do that. However, people with dementia will not be able to follow or join conversations and will have frequent word finding difficulties. Orientation. People with normal aging will be disoriented sometimes to day or the week, but usually they figure it out. They may go into a room or a place and forget why they were there, but eventually they recollect. However, in comparison, people with dementia will lose track of date, season, and time. They will lose in familiar themselves in familiar places. Um, and moving on to perceptual skills. Um, Usually, the people with normal aging will have visual changes due to organic causes such as cataract. However, people with dementia they will have problems actually interpreting the visual information, such as distance in the stairs or carpet patterns or reflections. Mood and behavior. Um, People with normal aging will be wary of work, family, or social obligations sometimes and feel a bit low or anxious. However, people with dementia will become withdrawn, they lose interest in socializing, they get unusually sad, anxious, or frightened, they become irritable or easily upset at home or work. This leads me to the next few slides on diagnosis and management. Please note the diagnosis part is I'm going to go through the history, examination, investigations, and differentials. In the management, I'll take you through general care, non-pharmacological approach, pharmacological management, preventive aspect, and a little bit on inpatient management and supporting caregivers. So let me focus on the diagnosis first. As with any clinical condition, history is crucial in the diagnosis of dementia, especially from the patient and informant. We already went through the cognitive domains. So, as with the definition, it's a progressive condition. So, it is a condition wherein the symptoms may have been there for a few months. It's quite important to get that history of onset and progression and go through each and every cognitive domains to see if there is any decline. Focus on behavioral and psychological symptoms such as anxiety, depression, hallucinations, agitation, personality changes, or losing in familiar places or wandering out of the house. People with dementia will have sleep disturbances, so it's quite crucial to get that history. Um, Again, people with dementia will have significant cardiovascular risks such as hypertension, stroke, diabetes, renal disease, and also look for any previous history of head injury. Medications, as with any older person, medication history is very important. Look for any anticholinergics that has been started, any benzodiazepines, or any antipsychotics that impairs the cognition. Um, Most importantly, do take the history on the daily activities of living to see whether there are any difficulties caring for themselves in finances, such as banking, driving, using simple appliances such as remote control, mobile phones, shopping, whether they are able to do it independently, cooking, prayers, any difficulties in performing or getting disoriented. Um, do get the history on smoking and alcohol consumption. Informant history, again, there are a few reasons why you need this. The early people with early dementia may not notice there are personality changes. It is usually noticed by the caregiver or the close family member. It is also prudent to identify the primary caregiver. It is important to confirm the symptoms which the patient is reporting, such as onset, progression, and functional aspects. Most importantly, it will give an opportunity to look at the risk assessment to see who is giving the medications at home, if the patient is still driving, and if there are any hazards in the place where the patient resides. Moving on to the examination part, you need to have all the vital signs documented, including heart rate, blood pressure, temperature, and do a good systemic review of examination, including neurological examination to look for any signs of neurological deficits. Also focus on the gait and Parkinsonism signs. Mental health assessment. Usually we screen for anxiety, depression using standard tools such as General Anxiety Disorder 2 or Patient Health Questionnaire 2. Cognitive assessment is the key in supporting your clinical suspicion of dementia. It is quite important you carry out a comprehensive examination. But do not rely solely on the scores in certain times when if you are dealing with people with learning difficulties, communication difficulties, or low educational status. The common tools that are used if you are in the primary sector, you can use the MiniCog, which is a quick test. It will give you it will pick up any abnormalities. It is quite sensitive. MoCA, which is Montreal Cognitive Assessment, is a comprehensive exam. It will give you information about if there is any cognitive domains affected and support your diagnosis. If you need a even more comprehensive mental state exam, you can go for Addenbrook's Cognitive Examination Test, ACE-3. We are fortunate to have neuropsychologists with us who can help us in doing very detailed psychological assessment and cognitive assessment especially when we are trying to distinguish normal aging with mild cognitive impairment or early dementia. In addition, sometimes if we have a differential diagnosis of dementia and other cognitive impairment syndromes, then we refer them for a detailed assessment. Um, it's also important to have a functional assessment carried out using standard tools such as functional assessment staging tool, FAST, or functional independence measure, FIM. We use FIM in our memory clinics. During the subsequent visits, we also look for any carer burden using standard tools such as Zurich burden interview. Which takes me to the next slide, which will help us rule out any reversible causes or any reasons why people have cognitive impairment. So I'll start with simple investigations such as blood tests. Usually we do baseline tests with looking for any vascular risks. In addition to that, a dementia screen with B12, folate, and thyroid function tests. ECG is mandatory in all patients because if we plan to start them on any medications, it's quite important that we have a baseline ECG to see if there are any changes that will prevent us from starting them. A brain scan will help us to rule out any reversible causes or underlying causes. It's quite important to consider that. However, for diagnosis of dementia, you require a detailed history with detailed cognitive assessment. In atypical presentations, we do a lumbar puncture and EEG, but not in all cases. So, as discussed earlier, for a diagnosis, you need to have significant decline in cognition from previous level. In addition to that, you should have a documented objective evidence of substantial cognitive impairment on neuropsychological testing. Along with this cognitive impairment should be having functional impairment with activities of daily living. There should not be any evidence of delirium. There may or may not be behavioral symptoms or psychological symptoms. With the diagnosis of dementia, depending on the presentation, you can divide it into mild, moderate, and severe. That leads me to the next discussion point on the types of dementia. The most commonest type of dementia is Alzheimer's disease, which usually presents as a gradual onset memory loss with lack of interest and depression. The vascular dementias present in a stepwise decline, with memory being affected to a lesser degree compared to Alzheimer's. Usually, people with vascular dementia are frail, with mood fluctuations. But in the real practice, you do see some kind of overlap between Alzheimer's and vascular. So you do see mixed type of dementia quite frequently, especially because of the comorbidities that people have as they grow older. Dementia of Lewy body has fluctuations in cognitive ability with Parkinsonism signs and hallucinations. Frontotemporal dementia presents a little earlier with personality changes, mood changes, and language impairments. With that, I'll move on to the differential diagnosis. Sorry again if my video is hiding some of the information behind, but I'm just going to tell you what exactly is there. Regarding the delirium, I think the experts from Oman will present that after my presentation. So you will be able to differentiate between delirium and dementia. I'll focus on mild cognitive impairment and depression. So let me go through few domains that are affected in these conditions, and I'll try to tease out the differences. So, with regards to cognitive domain, with dementia, there will be a significant, affection of one or more cognitive domains when compared to mild cognitive impairment and depression. Um, with cognitive impairment, it is usually significant in dementia and mild in complex aspect in mild cognitive impairment and depression. In depression, there is more preoccupation with symptoms. Um, Activities of daily living is significantly impaired as the disease progresses with dementia, and it will not be impaired in mild cognitive impairment. With depression, it will not be impaired. However, if it is significantly worse, then it may get affected. With regards to clinical features, there will be a significant array of symptoms in dementia with severe memory loss, visual spatial dysfunction, language problems, articulating problems, personality problems. With mild cognitive impairment, it is usually difficulties solving complex problems or multitasking. But the energy level and concentration will be normal in both mild cognitive impairment and dementia. However, in depression, the clinical features usually they present as loss of interest and pleasure, loss of appetite, decreased or increased sleep, psychomotor retardation, loss of energy, loss of concentration and focus. Finally, regarding mood, it will be normal in mild cognitive impairment. In dementia, it will be normal. Feeling of guilt and worthlessness is relatively uncommon. However, in depression, it will be low and rarely improves with stimulation and support. Suicidal thoughts and actions usually are common. Guilt or worthlessness usually common in severe depression. Um, Let me just quickly touch base on the reversible causes of dementia because they are potentially treatable, and we should hunt for these. As mentioned, brain imaging would be useful to look for any space occupying lesions such as brain tumor or subdural hemorrhage, normal pressure hydrocephalus, blood tests to rule out any vitamin deficiencies, and potentially they are treatable. Endocrine disorders such as hypothyroidism, chronic hypocalcemia, recurrent hypoglycemia, Addison's, and so on. Infections such as tuberculosis, syphilis, and AIDS. Inflammatory disorders such as autoimmune conditions like SLE, Behçet's neurosarcoidosis, alcohol-induced dementia. So it's important you know when to refer the patient for further assessment. So if you have come across a person with suspected cognitive impairment, based on the informant history, initial assessment, and a mini-cog, refer him to the treatment. If the patients are already on treatment and failing to improve after treating an underlying cause, such as, for example, if they had low vitamin B12 and you thought that could be the reason for cognitive impairment, and even after replacement it's not improving, then you should consider referring. We usually seek help from complex cognitive neurology. in cases which are rapidly progressing with focal neurological signs or suspected seizures or young onset or atypical presentation. In people with complex cognitive psychiatric issues such as behavioral symptoms severe enough to cause self-harm or harm to others, or severe depression or anxiety refractory to treatment, we refer them on to psychiatry. So that concludes the diagnosis part. I'm just going to move on to the management. Let me start with the general care. Older people with dementia, um, we should provide a person-centered care by addressing all the needs. Ideally, this can be done with coordinated care with one single coordinator who can organize um, all the care for the patient. It's quite important to plan ahead with advanced care planning to identify who is the decision maker, plan for escalation of treatments, plan for decision making in the future, and advance directives. As much as we can, we should try to provide care at home. Of course, if there is a time in future that they require 24-hour support and which cannot be delivered at home, then we can consider residential or long-term care. People with dementia are very vulnerable and are high risk for neglect. We need to have processes in place to safeguard this group of people. Don't forget, people with dementia will have significant comorbidities. Therefore, it's quite important to have a holistic approach in managing these comorbidities to prevent them to have frequent admissions or unnecessary outpatient visits to multiple specialties. With that, I'm just going to move on to the non-pharmacological management. Most important one is the psychological interventions like cognitive stimulation strategies, group therapies, involving occupational therapies to address any sensory impairments, physiotherapies, and various other therapies to help improve the quality of life. Additionally, person engagement strategies, for example, social interaction with the closed ones or the family members frequently, with a pattern to it. Music therapy, aromatherapy has shown to reduce behavioral symptoms and has also improved the quality of life. Bright light therapy has shown some benefit in people with sleeping disorders in dementia. And animal assisted therapy and multisensory stimulation, they are also useful for people with behavioral problems. Touch base on pharmacological management for dementia. Please note the pharmacological management may not stop dementia from progressing. However, it may help with some symptoms in some people. It's quite prudent that you do a ECG and renal function before you start any medications. As you're aware, the acetylcholinesterase inhibitors such as donepezil, galantamine, and rivastigmine, they carry side effects such as bradycardia, heart block, along with others, which can be easily prevented if we have a baseline ECG and a monitoring process. N-methyl D-aspartate receptor antagonist, which is memantine, It has got side effects such as dizziness, confusion, constipation. So they require a close monitoring of the kidney functions as well. Behavioral and psychological symptoms of dementia, BPSD. I'm just going to touch base a little bit on the pharmacological aspect. If you do find people with dementia to have anxiety or depression or obsessive compulsive disorder, then you might want to consider antidepressants such as selective serotonin reuptake inhibitors. The safest ones are the citalopram and sertraline. You can consider alternatives such as mirtazapine and trazodone. For sleep disturbance, ideally try the non-pharmacological approach with sleep hygiene, exposure to daylight, and exercise and personalized activities. Bright light therapy, as mentioned earlier, may have some effect. If the non-pharmacological approach is not working, then I would go with low-dose trazodone or mirtazapine or melatonin. In my practice, I usually start with melatonin at a low dose between 1 to 3 milligram. Remember, any sedatives you use, there is a risk of sedation, falls, and cognitive deterioration. That leads me to the final aspect of BPSD, which is agitation, aggression, restlessness, psychosis. Remember, antipsychotics carry a huge risk of stroke and mortality, and therefore it should only be indicated if severe challenging behavior and psychosis putting at self risk of harm or others. We use in our practice risperidone, quetiapine, olanzapine, or aripiprazole. We monitor them every 6 weeks and stop if there is no improvement. Again, important to have a baseline ECG and monitor as you go along. Preventive aspect, prevention is better than cure. So dietary modification right from the middle age with Mediterranean diet, which has shown to reduce the risk. Avoid red meat, sweets, processed food. Physical activity, amount more than the type, but good evidence for aerobic exercises has shown increase in cognition. Vascular risk factor management, tight control of blood pressure, good glycemic control in diabetes, dyslipidemia, obesity, smoking, and alcohol consumption. All of these has to be addressed individually to prevent any cognitive impairment in the future. Studies have shown there is significant risk of dementia with people who have hearing difficulties. Therefore, proactively it should be looked out and managed. Stress, again, with regular meditation, we will be able to reduce the stress, which also has shown to have a risk of association with cognitive impairment. Keeping socially active and mental well-being is quite important. It plays a role in preventing cognitive impairment in the future. So just want to touch base on the last slide on the management aspect, which is inpatient management. People with dementia, when they're admitted, studies have shown there is a significant increase in the falls, seizures, infections, delirium, and functional impairment. Therefore, it's prudent that we look into hydration, diet, keep them mobile, keep them supervised, minimize the multiple moves between the wards, and avoid unnecessary use of restraints. it's quite important that we support the carers because they have noted to have high risk of stress, anxiety, depression. It can be mitigated by education and training, providing support uh, with support services, and planning for the future. So, in summary, I took you on three main aspects, which we how to differentiate normal aging with dementia, diagnosis, and management. So, just some take-home messages. So, with normal aging, you will have minimal forgetfulness with full recollection as they try to recall. Um, they are able to plan and multitask, albeit may need to be more concentrating more. Um, Usually, there is no impact on activities of daily living in comparison to people with dementia. Diagnosis, history is the key, not just from the patient but also from the informant. As expected, it's a gradual onset history with one or more cognitive domains being affected. Neuropsychological testing with comprehensive, detailed cognitive exam um, is needed. Um, Hunt for any reversible causes as you can potentially treat them. Management, again, start with prevention, both primary and secondary. ECG and bloods mandatory before you consider pharmacological treatment. Consider non pharmacological strategies in all the patients. Um, Medications will not stop dementia from getting worse, however, it will help reduce some symptoms. Again, more important is advanced care planning and person centered approach. With that, I would like to thank Dr. Hanadi for giving me this great opportunity. I would like to thank the organizing team for organizing this excellent webinar, which is very much required. Thank you so much, everyone. Have a good day.
Assalamu alaikum, everyone. Good evening. My name is Dr. Nasser Al-Bulusi. It's a pleasure to be here today in World Alzheimer Day. And we could say now it's World Alzheimer Month because we are running so many activities to raise awareness about the Alzheimer disease. I'm Dr. Nasser Al-Bulusi, a specialist psychiatrist in Department of Behavioral Medicine, Old Age Psychiatry Division in Sultan Qaboos University Hospital, which is the academic lead institute here in Oman. I have graduated or I have finished my psychiatry training program in Oman Medical Specialty Board, and I have finished the requirement of the Arab Board Specialty of Psychiatry as well, and I am a member of Royal College of Psychiatrists. I would like to extend my thanks to the organizing committee for all the effort to make this meeting happen today. And I would like to extend a special thanks to Dr. Hanadi Hamid, the National Head Lead of Older People in Qatar, and Dr. Hamid Sinawi, our Head of Old Age Division department here in Sultan Qaboos University Hospital. We will be having a short talk today, and I hope it will be a fruitful one, and I hope you enjoy it. And if there is any question, you could ask later after the session, inshallah. So the presentation, the objective of the talk and presentation today, the main theme of Alzheimer's was actually is dementia diagnosis, getting it right. We thought to focus on a very important topic, which is delirium, and it's important in the sense that patients with dementia, they are at high risk of developing delirium while in a hospital. And I would like to highlight the objective for today's talk. So define delirium, and we will go through the diagnostic criteria as well as the neuropathophysiology, and we will touch upon the common used diagnostic tools, and briefly we'll talk about management, and then to highlight the common misconception among clinicians with regard so when it comes to the definition, the word delirium is derived from the Latin word of the track. So that's if the patient loses the track while or the attention while talking to you or engaging with you. And usually it's an acute change in mental status, and it constitutes of neurobehavioral syndrome, which is signs and symptoms that's mostly due to some dysregulation in the neurotransmitters in the brain. The diagnosis is almost made based on the DSM-5 and the gold standard criteria that we use and rely on to diagnose patients to have delirium. The patient should have disturbance in the level of awareness or attention, and that should be marked by an acute onset of the cognitive change. And mostly always is due to a medical condition which is evident by some labs abnormality or other investigation as an evidence for the cause for the and usually it would have a fluctuating course throughout the day for the patient. When it comes to the prevalence and incidence, different studies suggested different numbers of prevalence and incidence, and actually it varies among different settings and different age groups. So almost 20 to 31% of admission patients might have delirium, and almost between 20 to 80% patients develop delirium while in a hospital, and this range from 20 to 80, it reflects the different settings that the delirium occur on, which is almost sometimes in ICU settings, which is highly prevalent, post-cardiac patients, post-op generally, post-op patients as well, and other settings. Unfortunately, 30 to 60% almost of patients with delirium are not identified. And mostly it's due to maybe shortage of staff or very busy settings in emergency or even in the acute medical wards. And specifically the hypoactive type of delirium, it goes undiagnosed. Delirium is known as a medical emergency condition. So it carries serious consequences. Increases the patient's stay in the hospital, and with having said that, it will carry a higher risk of nosocomial infection because of prolonged stay. And definitely it is well known associated with an increased mortality rate, almost after 6 to 12 months. It doubles when compared to patients who did not develop delirium while in hospital, especially elderly people. And it might lead to long-term cognitive impairment. And definitely some of patients might end up with physical injuries, and that's almost due to the behavioral changes in form of being aggressive, trying to get out of bed, and pulling the lines, so that pose them at risk of physical injuries while in the hospital. Complications of immobility, and that's what we observe always when the patient is delirious, trying to move. The staff nurse or medical team, I would say, would advise that patient stay in his own bed, whether due to his medical condition or due to the behavioral symptoms he's developing. And definitely there will be an increased hospital cost because of prolonged admission. The field of delirium is evolving. We used to understand and know that it's commonly missed, and we have many factors contributing to that, as mentioned earlier. And it leads to serious consequences, as I have just mentioned. And unfortunately, it's not always reversible. Having said that, prolonged stay is one of the negative factor for delirium to have serious consequences. So duration and severity, as per the literature, matters in the outcome of delirium. Now the existing literature and the advances of research in the field of delirium is evolving as well. Now they are proposing different locations to be responsible for the presentation of delirium, different phenotype as well based on this location. And neuropathophysiology actually, there are some advances in the proposed theories and what's happening in the neurobiological level of delirium. And definitely not all delirium is equal is a proposed theory now as well based on the current literature. The phenotypes of delirium, the well-known ones and has solid evidence, is the hypoactive, hyperactive types, and we have the next type as well. And now the scientists and the researchers are talking about each type of delirium has its own pathway and its own way of management. These are proposed theories, as I mentioned. So they're talking about sedative, hypoxic, metabolic kind of delirium. Also, delirium has a specific entity that needs to be addressed differently from other types of delirium, as well as the one with related to anesthesia and ICU delirium. And there is as well an emergent evidence with regard a group of scientists or researchers working on pediatric delirium, and they are proposing a specific pathophysiology with regard to these patients. And we have the delirium superimposed dementia, which is quite challenging to diagnose in the sense that patients with dementia have a premorbid, I would say, cognitive impairment, which is almost sometimes resemble the presentation of delirium. And we have chronic delirium as well. Now, the literature suggests that many factors or mechanisms leads to final common outcome of the delirium. And there are 5 layers almost involved in the pathophysiology or neuropathophysiology of delirium. Neuroinflammation, oxidative stress, aging, neuroendocrine abnormalities, and diurnal sleep, melatonin dysregulation. All of this will mediate, will lead to the common pathway, which is the network disconnectivity and neurotransmitter dysregulation. It's unlikely that any one of these theories is fully capable of explaining the etiology or phenomenologic manifestation of delirium, but rather than 2 or more of these, if not all of them, act together to lead to the biochemical derangement and ultimately to the complex cognitive and behavioral changes characteristic of delirium. So all these proposed 5 layers are contributing to the development of the delirium. And when we say development of delirium, we mean that the system integration failure hypothesis, the proposed hypothesis behind the neuropathophysiology going on to lead to an acute brain failure, which is the clinical delirium phenotype that we see on the clinical ground. And as I just mentioned, most of us, we think, and the previous literature suggests it's only neurotransmitter, but the evolving research going on, they proposed network disconnectivity as playing a major role. And it happens mostly in patients with encephalopathy type of delirium, where this picture would show a functional MRI of a patient. In the upper one is that normal subject, and in the lower picture, if you could see the diagram, there is a loss of connectivity between the frontal cortex and the other cortices, and that happens in delirium. This table sums up the proposed hypothesis by Maldonado, and they are integrating basically the 4 or 5 layers we just explained underlying the neuropathophysiology of delirium, which are the the aging, anorexia, and encephalopathy, sleep deprivation types, dehydration, electrolyte stores. All of the 5 main layers we mentioned, oxidative stress, aging, in addition to the neuroinflammation and neuroendocrine changes, they highlight the end result of acute brain dysfunction and the neurotransmitters that's going to be affected in quality and quantity. This is, as I said, a proposed hypothesis based on the existing literature. And this table tells us how complex delirium is. And also it explains in part why not all patients respond to the same antipsychotic or same treatment. You could see from the table, different neurotransmitters are in different quantity and quality as well, with different insults to the brain. Now we will talk about quickly about screening tools that are commonly used in a hospital. We have the most commonly used is the confusion assessment method. It's widely used, and it needs that the one who's administering it have a good understanding of attention, and it needs some training as well. We have the 480 test, which tests alertness, attention, and the acute history. It has quite good sensitivity and specificity. It doesn't need much of training, and it could be used for emergency setting, or even an acute medical setting. We have the single question, which focus mainly on attention and asking the patient, do you think that the patient, asking the staff nurse or a relative that he has been confused lately. It has a good sensitivity as well to pick up the patients who are at high risk of developing dementia, delirium. When it comes to management, we have almost three categories. I would put them that way: early intervention, non-pharmacological intervention, then the pharmacological intervention. When we talk about early intervention, actually there are simple interventions like early mobilization. It has been proven that it lowers the risk of delirium. And actually there is an interesting paper called Burning Beds, and now that's not the 60s song, where the researchers has drawn the evidence of early mobilization and how it affects the delirium manifestation subsequently. So it's very important to have that strategy for patients, whether they are post-op, especially, or even elderly that has a long stay in a hospital that we need to make them mobilize as early as possible. There are other strategies like giving prophylactic antipsychotic, thiamine or melatonin. However, the evidence is still not solid for that intervention to prevent the delirium onset. One always should consider the context of the patient. The most important thing is the individualized assessment, considering patients' vulnerability, comorbidity, stage of illness, and the previous response to treatment. And obviously, person-centered approach is very, very important when it comes to either delirium or the behavioral and psychological symptom of dementia. So this takes us to the non-pharmacological intervention, and it involves always trying to avoid the mechanical restraint where possible, and even the pharmacological restraint. Keep orienting the patients to time, person, and place, and that should be happening frequently in each nursing shift. Early mobilization, as we mentioned, and providing some visual aids, adequate hydration, hearing aids if needed, to enhance the good sleep hygiene as well in a hospital if possible, and some cognitive stimulation as well. Having said that, we have to always entertain that there are other needs for patients to be addressed that might actually lead to exacerbation of patients' delirium, or even as I would say, emergent of delirium, which is addressing patients' needs in terms of hydration, treating constipation, pain management, as these are well-known factors to exacerbate the delirium, or even can lead to emergence of delirium. When it comes to the antipsychotic or the drug treatment, pharmacological intervention, there are different medication has been proposed to play a role, but the existing studies provide even only tentative support. The lack of evidence from well-designed studies is still there. The pharmacological management of delirium is often guided by empirical knowledge, not rather than a well-designed efficacy study. As I mentioned, our management should be tailored to be individualized approach to the patients, considering his comorbidities, stage of illness, and all of his needs. Currently, we are using the antipsychotic only when the patient is really having risk to himself or others, and that choice of antipsychotic should be really specific to that patient. Now, to make this very relevant, I will go through the most common misconception among clinicians with regard to delirium. Number one misconception is that this patient is oriented to person, place, and time. They are not delirious, but the evidence suggests that delirium evaluation minimally requires assessing attention, orientation, and memory, and the thought process. Ideally, this should happen at least once per nursing shift to capture the daily fluctuation. So at an instance when you go evaluate the patient, he will be well-oriented, attentive to you, but later on they will call you again that the patient is disoriented, he's distressed, he's shouting, and that's why the ideal way of evaluating is that it happens per nursing shift, so you could capture that fluctuation. Delirium always resolves. Now, the current evidence says that, especially in people or patients with cognitively vulnerable patients, delirium may persist up to 4 days or even months. And we have now the one type of delirium, which is the chronic delirium, and it needs to be actually addressed. We should expect frail older patients to get confused at times, especially after receiving pain medication. The evidence suggests confusion in frail older patients actually requires further assessment and to be vigilant for these high-risk patients. The goal of delirium workup is to find the main cause of delirium. Delirium etiology is always typically multifactorial. You cannot get one single cause for that. The new onset psychotic symptoms in late life represent primary mental illness. This evidence says that new delusion or hallucination, particularly non-auditory in middle age or older patients, deserve evaluation of delirium because most of the time it could be due to another medical cause. Delirium in patients with dementia is less important that these are already confused at baseline. Actually, patients with dementia deserve a closer monitoring because of the high risk of delirium, and because of that, delirium superimposed on dementia will have a serious consequences if left untreated, which might lead sometimes to dramatic, significant decline in the patient's cognition. Delirium treatment should include psychotropic medication. The best evidence says now that the role of psychotropic medication in delirium remains unclear. They are best used judicially, if at all, for specific behavioral symptoms rather than delirium itself. So it's just to control the behavior, not to treat the cause. The patient is delirious due to psychiatric cause. Delirium always has a physiological cause. It might resemble some behavioral and psychological symptoms of dementia, but it has a clear physiological cause that needs to be addressed and treated, whether it's an infection, needs antibiotic, or dehydration, needs some IV fluid, and other causes. Patients become delirious just from being in ICU. Actually, the evidence says that delirium in ICU, as any delirium occurring in any setting, it's caused by physiological or pharmacological insult. So it needs to be addressed and evaluated accordingly. Finally, the take-home message from this session, I would say and sum it up that delirium is common, especially with high patients with high vulnerability, and potentially have a very significant serious side effect. Vulnerability plus precipitant leads to delirium, which is secondary to acute brain injury, which is the system integration failure, suspected, tested, and treated. There is very little, but not negative evidence for pharmacological treatment. So at the end, what I would like to highlight, I would say to highlight that the most important point to our approach for patients with delirium, for individualized approach, patient-centered approach when we address patients' needs, looking into his comorbidities, stage of illness, and all the circumstances for that individualized case and tailor our management to that case. That's the end of my presentation. Thank you for listening, and I hope you enjoyed the talk. And I'm more than happy to have a later on discussion or any question you have, so we could discuss it. Thank you again.
Hi everyone, I'm Dr. Pravija. I'm a geriatric psychiatrist working in the Department of Geriatrics. Before I begin, I would like to thank Dr. Hanadi. She is the chairperson of our department. She's the national lead for healthy aging and the lead for Qatar National Dementia Plan. Thank you, Dr. Hanadi, for giving me this opportunity to be a part of this education session. And I also extend my thanks to Dr. Mani, who is a senior consultant geriatric psychiatrist, Dr. Shafi, the deputy chair for our department, and team of geriatric psychiatrists from Oman, Dr. Hamad and Dr. Nasser. Last but not the least, Mr. Mohammed Salih and Mr. Mohammed Mumal, our department secretaries, for organizing the event and for the support. Thank you. The theme for this year's World Alzheimer's Month is No Dementia, No Alzheimer's. It emphasizes the significance of knowing about dementia, the need for timely diagnosis. And as you all know, diagnosis, it's a process. It has its own implications when it comes to patient care or be it research. And when we look at dementia, sometimes the diagnosis may not be straightforward. It may be complex. So today I'm going to share a very interesting case with all of you. I have no conflict of interest to declare. Learning objectives, carry out an assessment for dementia, the significance of the multidisciplinary team when it comes to assessment and management of dementia. As I was mentioning earlier, dementia diagnosis can be challenging. Professor Bernard Isaacs, who is a professor of geriatric medicine, he coined the term geriatric giants. And in that, intellectual impairment or cognitive impairment is one of the giants. So it can be challenging when elderly people present with some of these symptoms. So why am I presenting this case today? One is that dementia diagnosis may not be straightforward. The second reason is our elderly patients present with a lot of comorbidities, and that makes it even more challenging. The third, we need the multidisciplinary team. We need the input and the expertise from other specialists. But at the same time, there should be an effective communication within the team members. Now, when we are dealing with a person with dementia, it is very important that there is one person, one physician, one member of that team who is holding responsibility for that particular patient. Because the patients and their caregivers, they're going through a lot of emotions. And having to speak to different teams, it can be even more confusing for them. So we have to ensure that this journey is, although it's a very challenging journey, but we as physicians, we need to ensure that we are communicating with each other, and we try as much as possible to ensure that we provide the person-centered care and make their journey even more smoother. So I will take you through to my case. A little bit of background. This particular mama, she's 71 years old. She has been in Qatar for a very long time. She lives with her husband and she's well supported by her daughter. She runs a salon. She's fiercely independent. Some of the physical health comorbidities include hypertension, hyperlipidemia, and she's on medications like aspirin, lisinopril, atorvastatin. She's on vitamin D3 and cyanocobalamin. She's a very pleasant mama, very kind and caring. How we got to know about this particular patient? Last year, we received a phone call in Raha. Raha is a National Alzheimer's and Memory Services helpline. Her daughter contacted us, and I happened to be there, and I was the one who answered the call. The daughter was very concerned about her mother. Her mother, who is very independent, who was managing her husband's, that is, her medication and his appointments and health related aspects, was getting a little bit disorganized. She was struggling to organize his medication, and apparently mama had contacted her daughter saying that she is struggling, and she was very upset about that. And this deterioration or this concern, according to the daughter, was happening for the last 3 weeks. So prior to that, the daughter mentioned that there has been some memory concerns for the last 6 months, which includes misplacing items occasionally. But otherwise, she was functioning quite well. She was managing everything. But in the last 3 weeks, there was this concern about her not being able to organize her father's medication. So the daughter wanted an assessment. So she wanted to make sure that if there is anything which can be done with regards to mother's memory, then she wanted that help. So when the initial telephone conversation, I referred mama to the urgent daycare unit, and here she was seen by the physicians to ensure that there is no underlying organic cause or any infection which may be contributing to this sudden deterioration which happened in the last 3 weeks. I also referred her to our geriatric memory clinic for further evaluation and assessment of the memory. She was seen in the daycare unit, all the blood investigations done, thoroughly examined by our geriatricians. There was no any underlying infection or any other factor which could be contributing to this acute deterioration. The outcome was she had vitamin B12 deficiency and she was initiated on cyanocobalamin. So we then see her in the geriatric memory clinic. I saw her in the memory clinic, very pleasant mama. She was, when I saw her, she was well oriented to time, place, person. She herself raised some concerns regarding her memory and some naming difficulties. And she would misplace items sometimes, and then she would forget where she's kept those items. And as part of the assessment, we referred her for neuroimaging and also for a detailed neuropsychology assessment. So MRI head, it showed some age-related global brain volume loss with some cerebral small vessel ischemic changes. So she presented with these symptoms first. These were the main concerns. Then we get she's waiting for the neuropsychology assessment, and then we get a call from the daughter who was in a state of panic, and she got concerned about her mom, and she mentioned to us that there has been a further deterioration. There was one episode where mama got disoriented to place. She informed the daughter that this is not her house, and she was requesting her daughter to take her to her house. And the daughter said they don't have any other house in Qatar. So the daughter was quite concerned that suddenly she's noticed this disorientation, and hence she contacted us. So we again wanted to make sure that there was no other underlying cause, and she was again evaluated. The neuropsychology assessment completed, and the outcome was probable vascular or a mixed type of dementia. In the neuropsych assessment, mini mental state examination was done, and she scored 20 out of 30. The dementia battery scale was done, and in that there was some indication of cognitive deficits. The assessment for her activities of daily living, instrumental activities of daily living, she scored 8. So there was only mild effect which was noted on her level of functioning. So once the neuropsychology assessment happened, she was waiting for a review in the clinic. So the daughter then contacted us again saying that Mama was having this difficulty where she misidentified her son-in-law to be her son-in-law's brother. So these episodes were happening, but she continued to be independent with all aspects of personal care. And so this is the presentation. There are these episodes where she's getting disoriented to place. Sometimes she's having these episodes where she was misidentifying her son-in-law. And then along with that, the daughter, so we continued to follow her up in the memory clinic. The daughter also mentioned that she was having some weight loss and that she's been having this weight loss for the last 1 year or so, and she's lost around 18 kilograms. So she was again evaluated and everything came back normal. And we looked at what the input which she was receiving from the gastroenterology team. They have been following her on a regular basis. MRCP was done and that identified IPMN. And hence the gastroenterology team was having a close input. Because of the complexity of the presentation and the way the cognitive deficits were happening, it's happening very suddenly. So, and it was very quick. So we requested a full neurology workup, and she was admitted to Hamad General Hospital for a full neurological, for a full evaluation by the neurologist to rule out if there was possible causes like a paraneoplastic, septic, metabolic. So EEG was done, CSF studies, MRI head was repeated. They also repeated the MRCP, and there was a slight increase in the side branch of the IPMN in the region of the pancreas. Colonoscopy was done, which came back normal. Now, while she was in hospital, there were episodes where Mama was getting a little bit distressed, and she was constantly worried about her children and her grandchildren, and she was very keen to go back home. Hence, they took discharge against medical advice, and she went back home. When she went back home, the worsening of confusion continued to be there, but this time, along with that, she presented with mood symptoms. She was very tearful, she was very anxious, and she was one of the reasons why she was getting very anxious was she has this partial insight. She knows that she's having these memory concerns, and that's frustrating her. And also she's constantly worried about her children. Her daughter, when she goes out, or even her husband, when she goes out, she constantly rings to ask where they were and when they were returning home. And when we tried to explore that further, there was an incident which had happened in the past. Sadly, Mama had lost her son, who went to work but never came back because he met with a car accident. And since then, she has been worried about her family members. She gets worried about her family members when they go out. So the increased anxiety was happening. So with regards to the MRI head, we thought let's revisit her MRI head, which was done, and get a neuroradiologist's opinion. So we got the neuroradiologist's opinion with regards to that, and there was a right side hippocampal volume reduction, which was noted with on the left frontoparietal area significant cerebrovascular changes. Worsening of cognition was happening. There was some impact on her activities of some of the activities of daily living. She was struggling with cooking, organizing medications for her husband. Her daughter had to intervene and ensure that she was supervising the medication. And at that time, our impression was a mixed type of dementia. But again, the challenges which we were facing was some of the physical health issues with the mental health issues, which was simultaneously she was presenting with. So this is our Mama. who is having problems with the memory. We are looking at the diagnosis aspects and the challenges we faced, the cognitive decline. It was happening very rapid. It was a rapid decline. She's presenting with the physical health issues where there is weight loss, and she's complaining of occasional abdominal pain is there. Now there is a significant caregiver stress. Her daughter, she's the youngest daughter, and she's the main carer for Mama. And for her, she was finding it very difficult to come to terms that her mother possibly has dementia. The other aspect was the family dynamics. So the younger sister, she has to keep the other siblings updated who are all living abroad. And they're all very closely knit family, and they're very much involved in the care of the mother. So it is the youngest daughter's responsibility to ensure that she is updating the other siblings, and if there are any concerns or anything, there were some differences of opinions with regards to the care and also with regards to how the youngest daughter was managing and supporting the mother. So we were faced with all these challenges, and on top of that, our own emotions of these diagnostic dilemmas which we were facing. So we decided that we will discuss this particular case in our complex case geriatric memory clinic neuro MDT. Here, thanks to Dr. Hanadi, she collaborated with the neurosciences department for this MDT to happen and take shape. And this particular MDT, we have the input from the neuroradiologist, the neurologist, geriatricians, geriatric psychiatrist, neuropsychologist, and psychologist. So when this case was presented in the neuro MDT, neurogeriatric memory MDT, and we decided that we should send for paraneoplastic antibodies and also request for autoimmune encephalopathy. So the FDG PET was done, and the FDG PET showed Alzheimer's type dementia on top of vascular dementia. So it's like a mixed presentation. But at the same time, there was also suspicion of malignancy because there was this right cervical and supraclavicular FDG avid lymph nodes, and also with regards to the gastric FDG, where they wanted to ensure that they rule out malignancy. So from a dementia perspective, we started her on donepezil, but unfortunately she developed side effects from the medication. We had to discontinue the medication. The encephalopathy autoimmune GAD65 antibodies, it was 0.17. So the other parameters, everything was unremarkable. Tumor markers were negative. So we then informed the family about this, had a discussion in our MDT. And also we had to ensure that based on the FDG PET, there are other, we liaised with the gastroenterology department to look into that aspect where the FDG reported that we needed to do endoscopy and rule out malignancy. And she went for ultrasound guided aspiration lymph node. MRCP was done, and there was an increase in size. So the gastroenterology, their plan was to monitor her very closely. So again, the decision outcome of the MDT was that we can start her on a small course or on prednisolone, and see how she responds to this. Here I would like to also mention, because the family are very much involved in the care, at the request of the family, they wanted us to liaise with one of the physicians, neurologists from Germany. So we had a telephone conversation with the neurologist from Germany, and he also agreed with the plan of a trial of prednisolone. And prednisolone was initiated. She was constantly monitored during this time in the daycare on a weekly basis. Initially, she seems to have responded to it. There was some improvement. The family said that executive function wise, she was able to, they've noticed some improvement, certain activities she was able to do. But after a few weeks, what feedback we got was there was a significant fluctuation in her mood. She was very tearful, she was crying. So we had to gradually start tapering the dose of the prednisolone. We had to initiate her on mirtazapine, the antidepressant. And at that point, we felt that Mama needed input from the psychology, and for the caregiver as well, the daughter, she was going through her own emotions and she needed support. So having this psychology input was very, very important at that point. So our psychology colleague, she started working with the patient and her caregiver. So the plan for us, the future plan, how we, the management plan for this particular mama is, we plan to repeat GAD65 antibodies. The multidisciplinary team input continues. She continues to have the input from the multidisciplinary team. We're continuing to monitor her in our geriatric memory clinic. We are monitoring her weight. We are collaborating closely with the gastroenterology team. There is collaboration, close working with the neurology team. And we are providing the support to the patient and her caregiver. Any concerns or anything the caregiver, her daughter wants to raise, we are easily contactable through our helpline. And this has been very reassuring for the daughter. And she also has access to our urgent daycare services. So if there are any concerns with regards to her physical health, she directly contacts the urgent care services, and arrangements are made for her to be evaluated by the physician. Because what we have noticed lately is that each time there is a slight increase in confusion. When she gets evaluated, the patient, it's noted that she has constipation. So that is also being followed up very closely by the geriatrician colleagues. Her daughter has been educated about how certain factors like infection, constipation, all those conditions, how that could have an impact on the memory. And she has very good understanding about delirium and how to recognize and ask for help as soon as possible. Now, this is a very emotional letter which her daughter has shared with the psychology colleague. And she has consented for this letter to be shared with everybody. And every time they ask, will we get our mother back? So they want their old mother back. And they keep asking this question. And it highlights how important it is for us to continue to provide that ongoing support and education to the caregivers. So this letter, the daughter has written for other caregivers to help them and have a better understanding. And it also talks about her emotions as well. It's a beautiful letter, which and it's very emotional as well. It's very heart-touching letter which she has shared. If the human brain were so simple, it would have been a lot easier. But thank you all for listening.
Good evening, everybody. Appreciate you staying through for the last session. At the very outset, I would like to convey my sincere thanks to Dr. Hanadi in organizing this webinar on the most important theme of World Alzheimer's Month, which is on diagnosis. And thank you for the support from Dr. Hamad Sanavi from Oman and my team here. So without further delay, we'll get on to what's this session about. Here we are going to take you through a very important facets of dementia. You have heard through from my colleagues in different aspects on the aspect of diagnosis, the challenges that it brings in. Here, the most crucial aspect, which is a century-old quote, which is summed up by a century-old quote from Sir William Osler. Listen to your patient; he's telling you the diagnosis. So I'm here today sharing you through one of the clinical cases that I looked after whilst I was working in NHS England. And this case still holds the test of time, typifying this quote from Sir William Osler. So without further delay, I'll take you through the clinical case. So as I mentioned, this is one of the patients that I looked after. We'll get to the story. At the very outset, I would like to declare there is no conflict of interest. So primary learning objectives, we are going to understand through this session the essential element. If you ask us, what is the one thing which stands out, or what is the one test for the diagnosis of dementia, I would still say it is history, history, and history. If your history does not fit in with the diagnosis of dementia, you will have to relook at it. And understand the importance of significance of collateral history in dementia diagnosis. So these are the two key learning objectives that this session will highlight. So I'll first take you through the clinical profile of the patient, and then we'll go through the background. So here we are. For the purposes of our presentation, we call her Miss Mary. So Miss Mary, she's 63-year-old. She is well known to adult mental health services. She was admitted to an adult psychiatric unit in NHS England, West Midlands. This was in May of 2012. That time, she is admitted following a deterioration in her mental state. Within a month of her admission to adult psychiatric unit, she's transferred to a general medical ward. And whilst she is in the medical ward, her diagnosis there has ranged from rapidly progressive dementia, neuroleptic malignant syndrome, Parkinson's disease, and encephalopathy. And after another 2 months of stay there, she's discharged to a long-term care nursing home with a working diagnosis of rapidly progressive dementia. And within a month of being in the nursing home, she's readmitted to the medical ward in the general hospital. And that time, I'm being contacted by the general hospital for giving a second opinion, as we run the geriatric psychiatry services. So we were contacted stating that here's a patient who has a rapidly progressive dementia. Can your services kindly take over the care? When we go to see her, when I went with my ward nurse to see her, so what we find is a 63-year-old Caucasian lady. And when we see her, she's lying in the bed in a very peculiar position. She's in a fetal position. And she's lying horizontally across the bed. She's not communicating. But she's able to follow us through with her eyes. It's evident there is no interaction from her otherwise. She's refusing any care, including diet fluids or any form of nursing intervention. So this is what we are seeing when we have gone there. So that's the profile that I gave you. Now we'll touch on the essentials on the history of how things led to where she was. So as I mentioned, 63-year-old, she's of a German origin. She was admitted in the month of May. But when you go through the background history, when you retake the history and details, what you find is that the weeks preceding, there have been ongoing concerns related to her mental health. She was taken to the accident and emergency weeks before with persecutory beliefs. She was worried that she had numerous unpaid bills and, she will be harmed by people. This was obviously contradicted by not corroborated by the family. Extreme fear and anxiety was evident in the weeks before. She was actually assessed by the crisis team, which looks after the accident and emergency mental health issues, and she was sent to be cared by the home treatment team. She was sent home to be cared by the home treatment team, but she went missing for 36 hours, and eventually returned home, fortunately safely. Our review did highlight the weeks preceding she had ongoing mental health symptoms, with her reporting of struggling to cope, her reporting of feeling horrible, hearing voices. She had clear signs of describing poor appetite, low energy levels. Her concentration was poor. There was lack of motivation. Even she had periods of fleeting thoughts of self-harm. In fact, there had been one occasion where she actually contacted the police, stating that she was going to stab herself. So you could see there was clear mental health concerns the weeks preceding this hospital admission to the acute psychiatric ward. And then when you go through her background history, the past psychiatric history, the story is quite striking. She has had, as this figure highlights, multiple bouts of major depressive episodes. Her first episode was in her early 20s, which was just in the context of postpartum. The subsequent episodes that she had was in the context of life events. And as you can see from the mental health services that were looking after her, they had periodically changed her antidepressants. And this was the third time that she was admitted to an acute psychiatric hospital during that period of journey. And towards the time that she was being admitted, she was on a combination of duloxetine and olanzapine. So this was quite striking information of her background. I'm not going to the details of background, personal, family, and social history. Just to highlight, there's a family history. Her sister had significant history of depression. She had a troubled childhood, from her personal history aspect. She had a difficult marriage, which led on to divorce. Following her primary education, she worked as an office clerk and subsequently as a shop assistant. No history of dependence on drugs or alcohol. She was retired and living in a rented flat when these concerns related to mental health resurfaced. Now, so when she comes to the acute psychiatric unit after this deterioration, what happened in that 1 month in the acute psychiatric ward? So in that 1 month, obviously, as the patient was unwell, they were looking at changing the antidepressant. So duloxetine was changed to mirtazapine, and the dose was further up titrated to the full dose of 45 milligrams. Olanzapine was also increased. So while the treating team is adjusting her medication and treating her, clinically, patient is continuing to deteriorate. And amidst this, someone has gone and done a cognitive assessment, a mini mental state examination, which on one occasion they found a score of 18, and subsequent weeks when it was repeated, they found a score of 8 out of 30. So whilst there is a decline in her physical and mental health, also new symptoms started happening in the ward setting. Evaluation highlighted, even though it was a retrospective evaluation, information highlighted she had bizarre behaviors. She would just come to the lounge area completely undressed, vacant staring gazes for long hours. She would maintain a posture and will stay in that posture for a long time. She also developed incontinence. So you can see, symptoms are just progressing while she's being treated in an adult psychiatric unit. Rightly so, the team went on to investigate. They did an MRI from an organic aspect, only mild subcortical vascular changes, nothing otherwise. Blood's unremarkable. And they obviously looked at further changing the medication. So the olanzapine was changed over to risperidone, and mirtazapine was changed over to escitalopram. which is what we routinely do. If a patient is not getting well after a period, you look at changing the medication. So this is what was happening. But whilst this is happening, her clinical condition continued to deteriorate. And actually, there was a serious medical event in that she was found unresponsive. And then obviously the psychiatric medication was stopped. She was transferred straight to the District General Hospital, to the medical ward. She was subsequently needed ITU care as she was found to have a complete collapse of right lung with aspiration pneumonia. She developed type 2 respiratory failure and she needed ventilation. Following on from there, she made a recovery from the physical health aspect and she was moved to the medical floor from the ITU. And while she was in the medical floor, that is when initially the differentials ranged between neuroleptic malignant syndrome and encephalopathy. She had neurologist evaluation, she had geriatrician evaluation ongoing, even a suspicion of Parkinson's was raised, and she was actually initiated on Parkinson's medication. The neurology team did further workup. She had full organic workup whilst there in the general medical ward, including CSF evaluation, creatine kinase, her autoantibody workups, including voltage-gated potassium channel, paraneoplastic antibodies, NMDA receptor antibodies, you name it. She had the full organic workup, including EEG, of course. And finally, as a conclusion, after all the organic assessment was through and her clinical condition was not showing improvement, the multidisciplinary team, the working diagnosis was kept as a rapidly progressive dementia. All the psychotropic medications were stopped. It was felt essentially she needs nursing care, and she was discharged to the nursing home. Within a month in the nursing home, she's readmitted to the general medical ward. And this is with concerns of that her dietary intake has further come down with poor oral intake, dehydration, and poor compliance. Not communicating with the staff, not cooperating with the staff, and that is how she's readmitted to the general medical ward. And that is when, as I mentioned earlier, this is the time they are contacting us for a geriatric psychiatry opinion. And I told you, as I told in the beginning, when we went to assess her, this is the picture we are getting. So here we are. So you heard the story of how the patient's clinical state reached where it is and how it is at this point in time. So you have the acute medical ward. You have the hospital managers there stating that this patient, multidisciplinary team, experts from neurology, from geriatrics, from adult psychiatry have evaluated, and now this is diagnosis is established. This is rapidly progressive dementia. We are not here to do anything more. Can you kindly take over to your old age psychiatry services for further care? And you have the hospital managers from the acute geriatric psychiatry ward, because there we have geriatric psychiatry has its own acute hospital unit. So the request was for us to transfer her to the acute geriatric psychiatry unit, which is a different hospital. But the hospital managers from there, which is my hospital at that time, so the hospital managers are telling me, well, Dr. Mani, she already has a diagnosis of dementia, and this is a rapidly progressive dementia. So can you, this is an acute unit. What are we going to do in an acute unit? Can you kindly get her to another nursing home? And you have the patient there in front of you. How would you proceed? Any thoughts? You can put your thoughts on the chat box. How should we proceed? Both in terms of evaluation and in terms of further management. It's a challenging scenario. How do you go about? So kindly share your thoughts in the chat box. If it was a live session, obviously I would have walked to you all and got your thoughts on how we should proceed here. but I'll now, of course, take you through what happened. You know, one learning that we want you to take is that, as I said in the beginning, history is the most crucial in the diagnosis of dementia. If your history does not go with dementia, you should never go with dementia. You have to always question, is there something else? Am I missing something here? That question, that burning question has to always be there. Yes, here, the multidisciplinary team has come to a diagnosis of a rapidly progressive, it could be rapidly progressive, one of those rare forms possibly, but am I satisfied with it? Have I made sure that I have collected all the information? So this is what we go through. So I have got the patient's daughter and collected the history. I've spoken to the treating clinicians. I've taken their information. But there is one more piece of information, one more, which is missing here, which is her medical file. So myself and my nurse, we start going through her medical notes, which is there at the time. We don't have the electronic records. So we have the doctor's medical file and we have the nursing medical file. So we scan through her admission notes, both from psychiatry and from general medical unit, through the notes. And it so happens that when we are scanning through the nursing, notes, we find a scribble of 2 lines written in the bottom of a page. And that is actually, a nurse has documented that patient has given us a letter, and it has been filed in the notes. Now, it was quite, striking for me, because when I look at the time of this documentation is the time when the patient's clinical state is how we are seeing her now. So, because she's been in that clinical state for 2 to 3 months. So this is just a month after she was, when she became unwell in the acute psychiatric ward and transferred to the general medical ward. This letter is written in the general medical ward. So we said we have to find out that letter. Very fortunately, it was filed in an envelope. And we opened the letter, and here's the transcript of that letter. As you can read, it says, it has a date. Now, that date is very significant. And so we obviously cross-checked the information with the daughter. So this is a letter written by the patient herself. Daughter confirmed the handwriting. Another striking thing is the date. When we look at the date, that date is actual date when there was a MDT team meeting taking place in the ward, in the general medical ward, to decide the future for this patient. So you have the MDT professionals sitting at one side and you have the patient who has written this letter. So it's in the same date. More so, in the envelope where the letter is placed, the patient has written the name of the treating consultant. The name is also correct name. It's just that she got the spelling wrong. And the content of the letter, if you read, as you can see, I used to work for social services, which I enjoyed. I had to go to base 17. I was very ill. Now, base 17 is the ITU bay, from where she was then transferred to the medical bay. So she's right there. I was in bed 2 to 3 weeks. Sometime I would speak to Rachel, which is her daughter, name changed for confidentiality purposes. Times stare into the space. My family have been crying in despair. I hope to be independent, wish to go home, hope to be independent, watch TV, listen to the radio, fetch a little bits of grocery, worried about climbing stairs. On the mental state, still what we are getting is a limited cooperation. Periodically her gaze is fixed, she's mute. So we find this, we got this letter as I highlighted the aspects of the letter. And then we are sitting there and we are looking at the letter. You have the patient there and you have the hospital manager of this and the hospital manager of the acute psychiatric ward, trying to get the patient to move to another nursing home. How do we go about? Now, this is where the beauty of science is, the beauty of medicine is, the beauty of Sir William Osler's statement, which was made years back, centuries back. Here is a patient telling us a lot of things. You know, if we take the diagnosis as a rapidly progressive dementia, now in this clinical state of what I have described you know, a patient, would be classed as an end-stage dementia. So in an end-stage dementia, a patient cannot write what she has written. Patient fully knows where she is, what is going on. More so, she actually knows that on that day, at that time, there is a multidisciplinary team taking place which is going to decide the future of her care. She is telling them what she wants, what is her wish. And they are sitting there and writing that the patient lacks capacity. They have to make the decision on the patient's best interest. Now, this is the beauty. This piece of letter challenges the diagnosis. This is not dementia. This is something else. Let's look at her further. We go back to her bedside. And this time when we are looking at her, we just thought we will give her a glass of water. We give her a glass of water. She moves her hand, but she doesn't move her hand to the cup. She keeps it in the middle. Ambitendency. She's lying down. So what we do is we just take the pillow. She's got a pillow. So we just move the pillow. This is her head. It's not going down. It's in that psychological pillow. We ask the nurses, does she walk? Well, sometimes she walks, but doctor, she walks in a very odd way. What is that? Then the nurse shows the walking. It is tiptoe walking. Well, mute, immobility, periodically staring gazes, tiptoe walking, ambitendency. The more we are looking at it, this is catatonic signs. We bring in the Bush-Francis catatonia rating scale, and out there, she has quite significant catatonia signs. So as you can see, once we have got this, we look at the differential diagnosis. So for us, the first differential stands at catatonia. The rest comes after that. Okay. So yes, we have kept a rare form of dementia because obviously that was kept in the differential. But for us, that comes down the line. For us, the catatonia remains on the top. We take up to our acute. So we have a case to hospital manager. Yes, we need to get her there to our unit. So we move her to our geriatric psychiatry unit and we initiate our assessment and management. So obviously once she comes over there, her physical examination is unremarkable. What we do is after the first 2 days of evaluation there, we initiate trial of lorazepam. And it was magical. So she has a milligram of lorazepam, and then after an hour or so, the nurses are coming and saying, "Doctor, she's walking, she's sitting and talking." And she's asking for food. She's communicating with the nurses. It was quite striking to see the difference there. But of course, it was only short-lived. Within an hour or two, she was back into the non-communicative phase. But that added to our clinical suspicion of catatonia, where lorazepam has the evidence base in terms of its magical impact. So we made the lorazepam regular. We initiated aripiprazole. We took her co-careldopa off because we felt the rigidity was more part related to the catatonia as opposed to Parkinson's. And as we gave the regular lorazepam, we did find more and more periods where she was more brighter, more animated, and more communicative. Though still she was getting back to the mute periods. She was still incontinent. She still needed assistance of the staff for her nursing care. But as we started communicating through her in these spells where with lorazepam she was out and talking, We could elicit there were depressive features. We could elicit there were psychotic features. There was an unexplained fear. We discussed with her the options of electroconvulsive therapy. Of course, there it is under the Mental Health Act. We actually carried a Mental Health Act assessment. But it so happened, whilst in the assessment, because it was in a phase where she was communicating, she had the capacity to make the decision. She herself said, I am feeling better with what you're treating, doctor, and I would like to the treatment further, what you're suggesting. And we went ahead with ECT as an informal patient. And first couple of sessions of ECT, we didn't have a sustained improvement. But after the fifth ECT, her mental state continued to show a sustained improvement. Her diet and medication compliance improved. She began to engage in a self-care. She in fact was asking referrals. She said she has a dental problem and she wishes that to be evaluated. Her mini mental state examination, which is the cognitive test, also started improving. As you can see here with the date and the evaluation, on the top you have the cognitive scores, the mini mental state examination, and down you have the hospital anxiety depression scale. As you can see, as the treatment progressed, her scores were improving. Her mini mental state examination, towards the end of ECT is come to 29 out of 30. So we continued full 10 treatments of the ACT. She is independent of her activities of daily living. Her oral intake improved. She's continent. So the incontinence is out of the window. Self-care, she's independent, improved. We adjusted the medication, as you can see there, antipsychotic, antidepressant, and the lorazepam there. In the mental state examination, which I still vividly recall and still vividly remember, it's 10 years down the line, but still I picturize the day she came and sat in the ward round. You can see the feminine groom, the grooming, the interest that she had come back, and out there she was sitting, looking lovely, going through the ward round, appropriately dressed, good eye contact, rapport, reactive, cooperative. She was very happy with the progress and the improvement she had. No agitation, no psychomotor retardation, well communicative, no formal thought disorder, no depressive cognitions. In fact, the cognitive scores were 30 out of 30 with good capacity and insight. She understood that she has a depressive illness, which led to the complication of a psychotic depression going into the catatonia. She understood the importance of the treatment that helped her, understood the importance of continuing to take the treatment with a very full insight. So there, a diagnosis of a rapidly progressive dementia, when we have followed what Sir William Osler taught us centuries back, we could challenge our own clinical diagnosis. That challenge could help us look into what we are missing. And, we could, I think here another most crucial information is, that piece of letter from her. So that part of the collateral information. So when our diagnosis is not clear, every piece of information is important. So that's a little piece of information enabled us to relook at everything and give her the treatment that she deserved. She was fine, better. We transferred her back to the adult psychiatric services. They moved her to the rehab setting for her to get back to her life. So I sum up the two important learning objectives, that history taking. If I had not got that history, she would be in a nursing home with a diagnosis of a end-stage dementia, rapidly progressive dementia. Here her life is back. Another important piece of information which we would like to share is that, acute mental illness, there is no point of going and doing a cognitive assessment, be it MMSE or a MOCA. You will get the scores down. The problem then happens is, when the scores are down, then the clinician is looking at it from a dementia perspective and is not going ahead with the acute active intervention that the patient deserves. So these are sort of the pearls that we would like to share. Thank you for your attention and wishing you all a good evening.